I now have the pleasure to present Dr. Arun Sanyal. He is a professor of medicine at Virginia Commonwealth in Richmond, Virginia. Dr. Sanyal.
Thank you. Great start this morning. Let's see. Okay, so we're going to kick off this day by talking about some general principles about clinical trials. And what I'd like to do is share with you sort of how I approach it. It's not necessarily how everybody approaches it, but this is just to give you a sense of how, one might think about things. So I'd like to think about reverse engineering. Before you start your trial, you got to think about what is it going to look like when you finish your study and you're sitting back and everybody's telling you what a fantastic job you've done when you have your paper in the New England Journal, which is what many of us in the academic world aspire to get, right? So think about what the trial should look like. And the starting thing is right at the top. Why even do this trial? Who cares? If you cannot answer the who cares, if you cannot get passionate about the who cares question that you're trying to answer, then you got to really take pause and ask yourself, is this worth moving forward? Then there are issues about the methodology, and we'll get into that, the results, how you plan to interpret the results, and you really can't do this after the fact. You got to have an idea of what data you're going to collect, how you're going to interpret the information based on your hypothesis, and then how you're going to adjust for things, and what things can you predict ahead of time and plan for so that you don't get tripped up. So let's walk through all of these things. So what I'll talk to you about is some broad concepts about design with a focus on clinical trials. Talk about p-values and type 1, type 2 errors. Some of the issues with subset analysis, and we see this all the time, particularly, certainly in the hepatology literature. And then, as Ray mentioned, elements of causation and causality, and some of the pitfalls around the p-values. All right, so there are different types of studies, and there is a hierarchy in terms of the quality of what we consider the clinical trial to be. So it can start with a case report, where you can just say, hey, I had this patient, it's a little bit of an anecdote. Then you have case series, where you have a bunch of patients, and this could be prospective or retrospective. Prospective's always better. Then you have case control studies, where you're actually trying to control for some exposures, so that you're looking at people who either had a risk factor or didn't have a risk factor and see what happens to them. And these are primarily retrospective as well. And then you have the randomized controlled double-blind study. So there is a staircase effect. There is a stepwise hierarchy of the quality of the studies. The lower you are in this, the lower is the level of confidence you have that you are actually going to assess the truth. The higher up you are in the hierarchy, the closer you are, you're more likely to be getting to the truth. Because ultimately, that's our goal, right? We want to seek truth in establishing cause and effect relationships, whether it is in terms of establishing that a risk factor causes a disease, or how it interacts with other risk factors to cause disease, or how an intervention actually reverses the disease process. Or if you have a biomarker, how that biomarker relates to a specific disease process. So it must be designed to minimize chance, which is random error, and avoid bias and confounding. Because if you throw stones in the dark, sooner or later you'll hit somebody. But that doesn't mean that you can do it every time. So this leads us to what we call the placebo effect. Of course, comes from the Latin word, I shall please. And it can actually improve health in a small subset of people, because the power of suggestion is pretty strong. And it's a conditioned response based on trust, and is a brain-body phenomenon. We actually don't understand the placebo response in many disease states very well. But certainly, this is something that you have to keep at the back of your mind when you design trials, that there's a certain amount of effect. Part of your effect size is just from telling people that they may be getting exposed to an effective intervention. So this is really at the core of your study design. This is the simplest form of the study design, where you take your population of interest, you preset your criteria for who you're going to study, whether you're going to study the whole population or a subset of that population, and take out the people who do not meet your criteria. Once everybody meets selection criteria, and you have to document that you've actually met those criteria, then you randomly assign them to different groups, and then you follow them over time, and you look at your outcome of interest. So why randomize? Well, randomization avoids bias in assignment. So you could systematically say NASH is a hot topic, take everybody who has NASH and diabetes and put them in one group, and people who without diabetes in another group. Well, if it turns out that your response to whatever you're doing is contingent or modulated by diabetes, you're going to get very different results in the two different groups. So you have to avoid bias in assignment. It's more likely to distribute known and unknown confounding variables. And there's certain confounding variables that we're all aware of in any given disease state, but there are complex confounding variables that we have no clue about. So if you take complex diseases, for example, cirrhosis, where you have etiology, BMI, use of statins, beta blockers, antibiotics, everything that is going into the mix, and in various permutations and combinations across individual patients. And now you come in with a completely new intervention. You want to make sure all of those different things distribute equally across the arms. And of course, the statistics used assume random distribution. The outcome of interest is when you have two arms. One arm is better than the other. That's what you're hoping. You're hoping to have a positive study, right? So that's when typically you get something and your p-value is less than 0.05. So if there's one message I want you to take home today, is don't marry the p-value. Flirt with the p-value, date the p-value, don't marry the p-value, because p-value will come back to haunt you. So even when your p-value is less than 0.05, it is statistically significant, but what does that mean? It means that there is a likelihood, there's a 1 in 20 chance that you got this result by pure chance. So it's a low probability that this occurred by pure chance. It doesn't mean you've reached the truth. So there are at least 4 possibilities when you have a p-value under 0.05. One, that truly one arm is better than the other. The other is that you got struck by lightning. You got that 1 in 20 chance that you actually got the wrong result by pure chance. So if your p-value is 0.01, you reduce that likelihood. Or it's a confounding error, that you've got other confounders that are causing one arm to look different than the other. And lastly, that you have a systematic error in the way you have put your study together. So there are at least 4 possibilities. When you read a paper where it shows a significant difference between groups, or when you're designing studies, so you've got to think about these and try to prevent these if you can. So the p-value is essentially the probability that differences observed of that magnitude could have occurred by chance alone. So that's really the key you have to remember. So it's a dance between the effect size, how much of a difference there is between the two groups, and the sample size. So you could have a very small effect. If you have a large enough sample size, you'll get a p-value. Doesn't mean you've magically cured something. On the other hand, if you have a huge effect size, you don't need big sample sizes. So you have to understand exactly what the p-value actually means. So we already talked about this. So this leads us to a historical person, and that is Sir R.A. Fisher. So how many people here in this room, Ray excluded, know how the p-value came to be of 0.05? How did we land at 0.05? Where did that come from? So Dr. Fisher was a statistician in the agriculture department in the UK. And A bunch of farmers came to him and said, we use this different fertilizer, and this year our tomatoes are much bigger. And is this because of the fertilizer? He said, for the last 20 years, what have you been using? He said, oh, we used a different one. And he said, this year's the first time you used a different one? He said, yes. Well, there you have it. It's due to, this is because of your fertilizer. That's how the p-value of 0.05 came to be, 1 in 20, okay? It didn't come from God. It's not written in any religious book. It came from Dr. Fisher, and that's how it came to be. So you got to understand what that p-value actually means. So then the second, so the p-value, so the second type of thing you have to remember is that you can get a p-value if you have very small sizes, you can have imbalances. So you might get a p-value even when there is no real difference if you have larger studies, and that's called a type 1 error. A type 2 error is the p-value, you miss your p-value. And then everybody will say, oh, the study was not significant. But that may be because you didn't have a large enough sample size. Remember, the p-value is a dance between how much of a difference there is between the two groups and how many people you've put in the study. The larger the sample size, you need a lesser effect size to get a p-value. So as long as you understand these core concepts, then I think you'll be on the right track. Then you come to statistics. So you know there are lies, there are damn lies, and there are statistics. So this is a great study. This is a sepsis study. And based on proportions, no significant difference for use of steroids. But the same study, when they plotted it with Kaplan-Meier and did a Wilcoxon, suddenly they see a statistical significant difference. So where is the truth? How do you get to the truth? So you have to address various types of, so you got to know what statistical methodology you'll use. You got to say it up front. And then you also have to address confounding variables. So confounding variables, so the first reason why you get a p-value is your one group is better than the other. Second is that you got struck by lightning, bad luck, you got random chance. Third is you got confounding variables. So how do you address confounding variables? Because increasingly we are dealing with complex. We're not dealing with pneumococcal pneumonia anymore, where you have a bacteria, single bacteria causing a single disease with a singular outcome which can be easily measured. We're talking about complex chronic diseases. So you have to match as much as you can at the front end for all the different confounding variables. Then you can stratify either at the front end or on the back end. For example, diabetics given drug A versus diabetics given drug B. And so you can, in NASH studies, we frequently will stratify for diabetes or absence of diabetes. Or you can model at the back end with logistic regression to see which are the independent factors. Did your therapeutic actually come out to be a key driver of the clinical outcome? Then there are issues of subset analysis. The next thing you got to is be very wary of subset analyses because these are not usually part of the randomized trial. They are highly susceptible to confounding and bias and should not be accepted as cause and effect unless it's an a priori part of your analysis. So you got to ask yourself when you see subset analysis, was this a post hoc subset analysis? Or was this part of your primary design that you planned for it and you accounted for it in your statistical design? So even if significant and true, then there is another layer. The question is this clinically relevant? So you can have a huge study. Is it clinically relevant? So, you know, you can have a study with 10,000 patients. So the PCSK9 story for cholesterol is a great story, because they did these trials with 20,000 patients in each trial and found a p-value, but it's so modest that nobody believes that it adds value to the patient. So it is having a rough time actually coming into clinical practice, even though the drugs sort of work. So you not only have to hit all your statistical endpoints, but then at the end, you have to ask yourself, is the effect size that you're going to measure clinically relevant? Is this, how much of a change is meaningful for your patient? So that brings us to the causality issue, which is when you see the change, how confident are you that you've actually found the truth? And for that, you know, this is again historical. Sir Austin Bradford Hill, he's really sort of the pioneer and a father of how we think about all of this today. And he was a pilot in World War I and got TB and ended up getting economics, studying economics because he couldn't get into a medical school. But he was a statistician evaluating the first randomized trial for streptomycin for tuberculosis and established essentially our current checklist for how we assess causal inferences. So if an association, if you do two things, you make an intervention and you find a p-value, question is, are these still causally related? Just because you have statistical p-value, it could just be an association. Associations do not make causality. My mentor used to talk about telephones and toilets in terms of making this issue. Every house has a telephone, every house has a toilet. Doesn't mean every time the phone rings, you got to run to the toilet, unless it's your boss. So the associations do not make causality. And what we're trying to understand is truth, causality, as Ray pointed out earlier today. A critical issue is temporal sequence. If someone's had the disease for a very long time, you make an intervention and you see the cause before the effect. That helps you, gives you confidence. Biological plausibility. So many people do these bizarre studies just because they thought, let's just throw something at this disease and see what happens. There is no biological basis to even think how this would even work. You got to think this through. You must understand the biology of the disease and think about the biological likelihood that what you're going to do actually is going to produce something that makes sense biologically. Dose response, exceptionally important. People do these early phase studies and then they come out and they say, oh, now we're going to go straight to a pivotal trial and we're going to cure the world. Many of those studies will fail. One of the most robust things that will tell you from your early studies that you're likely to succeed later on is if you see a dose response. Consistency. Association holds under varied conditions. That's why you do a phase 2A, phase 2B, before you go into the huge phase 3 trials. The strength of the association, of course, the bigger the effect size, the more confident you are that this is a real finding. And then specificity. If a risk factor is fixed, and then your effect goes away, and then you reintroduce it, like the Koch's postulates. So, obviously, that's not applicable in all circumstances, but these are sort of at least 4 or 5 things that you need to think about when you read a paper or when you are planning your study, so that at the end, when you put this whole thing together, you need to be able to tell this story in your discussion about why what you have done makes sense, that you are actually getting to the truth. And because that's what goes into your discussion ultimately when you write up your paper. So again, over here, there's just an example that over here, there's a lot of literature about antifungal prophylaxis and documented bacteremia in febrile. It's just an example, but it shows 20%. So this was a meta-analysis. And these authors, they said 20% if no antifungal antibiotic, that's the bacteremia rate. And it was 26 to 27% if you got antifungal. So they concluded antifungal use causes increased bacteremia. But then they went back and looked at this again. And they said, well, let's go through this checklist. It's possible that it was true, or it could be random error or confounding, or we have a systematic bias. So again, what they find is that most of the people who received prophylaxis did so in the late years of the study, and most of the people who got placebo were in the early years of the study. And so, this was a mismatch of studies that went into a meta-analysis, and this is a systematic source of bias. So clearly, as standard of care changes, things change. And so you got to be aware of these possible biases. Also, they found that one of the antibiotic regimens was particularly ineffective in preventing bacteremia. And so there was a background of other antibiotics that were given that also confounded. So you have to be very careful about interpreting. And there's a lot of discussion back and forth now about prophylaxis with antibiotics in the context of ascites. And many studies suggest that if you give antibacterial prophylaxis with fluoxetins, you get increased multi-organ, multi-drug resistant bacteremias and fungal sepsis, et cetera. So I think we have to really be very critical as we read through those type of literature, and there's an urgent need for a properly done, prospective, rigorously controlled study so that we can address all of these different confounders. So again, coming to biological causality of linking the use of antifungal therapies to the development of bacteremia. There's no really models to base biological plausibility here. The magnitude of effect was modest. The dose response was not shown. Specificity was not shown. So in the end, this was put away as, we really don't know. This is what we call soft truth as opposed to hard truth in science. So there's a lot of this type of stuff, even in the hepatology literature. Now that you think this way, go back as you read your papers in hepatology, in the various journals, you will find so many times these are not really critically addressed. So, of course, this paper, I admired this team because they went back and reanalyzed their own data and came back and said, this is what we said, but having reevaluated all of this, we think that we may or may not have the right answer. So again, at the end of the day, you need to address those 4 differential diagnoses of your p-value. You got the real truth, you got struck by lightning, bad luck, confounding, or systematic bias, and causality. So the take-home points at the end are, in trial design and in choosing to read a manuscript, is the question important? Very important. This is your starting point. If you go wrong here, everything else goes wrong from there on. The design process, is it rigorous? Have you presented the results clearly, and is your discussion fair and unbalanced? Unbalanced. Freudian slip. For every p-value, think about the 4. That's what I really want all of you to take home. For every p-value, understand the differential diagnosis of a p-value, significant p-value, truth, and 3 possible errors. So you have 3 out of 4 possibilities that you're wrong, even when you have statistical significance. And sometimes when you're not significant, you could still have a good effect. Just because a p-value is 0.06 doesn't mean a drug does not work. Maybe you just didn't have enough patients. Your effect size is not quite as big as you thought it was going to be. So beware of actual and hidden subset analyses. People will sneak in. A great example is use of factor 7 for variceal hemorrhage. The first study, no effect. But they said, well, if they were spurting and this was happening and that was happening and the blood pressure was 60, we found some difference and that was a subset. So then they did another huge study. Guess what? Negative. So we could have predicted that. And that was a huge amount of money, effort, energy that could have been used for something better. So think about this as you plan your studies and read manuscripts. Lastly, we all read papers. All of us do not do trials, but all of us hopefully read papers. Be critical of the study design. Think about how they've put the study together. Was the question right? Was the hypothesis? Did they frame the population correctly? Did they exclude people with confounding? How did they address confounding? Did they stratify? How did they measure the endpoint? Did the endpoint really reflect what they were trying to get at? Are the statistical analyses robust? And then lastly, step back again at the end, step back again and say, how does this change the way I think about what am I going to do tomorrow in my clinic? Is this going to change the way I do business every day? So you have to start with this question. You end up with the question and say, how does this change my world? And you really have to think about this before you start your trial. And most diseases, remember, chronic diseases, we're talking about NASH as a hot topic, have multiple causality factors. And so these regression type models and now machine learning and other tools that are coming on board are really helping us resolve this issue of biological complexity. So this is, I think, the last slide. So remember, study design, greater confidence with clinical trials than case control over case series than case report. Every p-value has a differential diagnosis. A p-value less than 0.05 may reflect a type 1 error. A p-value greater than 0.05 may represent a type 2 error. Subset analyses are dangerous. Be very wary of them. P-values do not mean clinical value. And if a p-value is less than 0.05, seek the cause and effect elements. If you don't meet that, then suddenly you have a question mark in front of your interpretation. Thank you.